who's almost asleep doesn't get confused when she wakes up and hears me talking about a bug called CNS. But the additional virulence and resistance gene in USA 300 are also from staph coagulase negative. Now, why does that worry you?
Because they're going to mutate.
In particular, what resistant? What antibiotic? Vancomycin. I mean, why it hasn't happened sooner, nobody knows. It's probably one of the biggest mysteries microbiologically. But we have had isolates here. What are the highest MIC to vancomycin we've seen in coagulase negative staph? Pat, do you just off the top of your head? I've seen 16 reported. MICs is 16. That's virtually highly vancomycin resistant. If it's just translocation or transposition, phage mediated, nobody knows how it happened. But if that happens at some place somewhere in a USA 300 strain, we're in deep trouble. Because then we're running out of bug juice. Serious bug juice. But that doesn't cost an arm and a leg. Or break the bank. Phil, you know I hate to say it, but this isn't working. Oh, now, did you just move it? Could it be? Oh, jeez.
So this is for
Mary and Joseph.
right arrow. Forward.
I knew that. I was just checking.
Is that maybe a doctor?
Smarter than the doctor, yeah. So what are the most accurate methods? Just to remind everybody for detecting MRSA, the most accurate method is PCR for the MECA gene. And a latex agglutination test we talked about for the PB2A if you want to report in a short period of time and not wait till that evening. To really know if you're, to do active surveillance, you have to do nares, axillary, and rectal cultures. When you leave one of these out, you're reducing your retrieval by a third, usually on the average. The thing that doesn't get remembered in screening patients is open lesions that aren't healed. Scrapes, bruises, postoperative wounds that are less than 14 days old. They are often colonized with Staph aureus, MRSA, MSSA, it doesn't matter. And people often forget to do that. This is one of the highest risks for a post-op wound infection you can get, is an open lesion that hasn't been treated. And for an elective procedure, I don't think they should be done. I think you should send them home, have them clean the wound. It may just be colonized with MSSA or MRSA, but you're better off sending them home, having them epithelialized, and rescheduling when there's no open active wound in place, because that will almost always not be colonized by coag-negative staph, which normally protects from coag-positive staph or Staph aureus colonization, right? If you just do nares cultures alone, you miss 27% of MRSA carriers. So, Montana, there's no political involvement with MRSA surveillance cultures. You know what the law is in California? The state law? Every patient admitted to the hospital has to be screened for MRSA with a nasal swab by PCR. It's a state law. And they'll punish them if they don't do it. That's an incredibly expensive, time-consuming procedure. Mandated by a legislature that was in a panic over MRSA when the initial outbreaks occurred back 5 to 7 years ago. You had those 3 little kids that died in Minnesota. They had probably had a USA 400 strain, in retrospect, a highly virulent infection. They were dead in 48, 72 hours. Then they came up with the butt pus and realized butt pus was going on, but it turns out it's only a very small fraction of the USA 300 strain that causes that horribly aggressive, virulent, highly toxic septic shock, you're dead in 1 to 2 day kind of picture. But it wasn't before states like California didn't go into full panic mode. And there's other states. I think Nevada's another one, and there's a couple other southwestern states. And I don't know what happened out east. Usually they're arguing with each other so much they didn't realize the kids had died for a year or two. But in the West, it was a panicky situation. And that has led to an awful lot of misallocation, I think, of resources.
So are they?
Because they're missing 27% of the carriers by law in California.
Are they
Yeah,
isolating those patients?
they isolate them, absolutely.
And then decolonize them? 'Cause that's
They don't. We'll talk about that, but
Yeah.
they don't try and do that. They cohort them and isolate them, put them in contact precautions. You know, there are countries in Europe, Holland's one of them. They are absolutely insane. They won't accept a patient with MRSA from outside the country, even if it's their own citizen. Get sick in Germany, you stay in Germany until you're better. You can't come into our hospital system. The Germans haven't had that. They have a lot more problem with nosocomial MRSA. The Dutch, they don't have virtually any. I mean, they have thrown an enormous amount of resources into cohorting, isolating people that are documented as having MRSA. They even have special wards where they put them on. They put only, you can only be on the, if you have MRSA, you can only go to certain wings in their larger hospitals. And they will not, you cannot get back in the country with a diagnosis of MRSA infection or colonization if you have to be hospitalized. You can't be hospitalized in Holland from outside that country, MRSA. That's how, and so that's one extreme, and the Germans are the other way, but, and again, they're the ones with the E. coli outbreak and the hemolytic uremic syndrome, so God knows what they're doing. But, I mean, this has gone, this surveillance issue has gone a long ways. So should we do them? You know, the ones that are probably the best to do if you're going to do it, if you can afford the PCR or the machine, whatever gets cheaper. I know. We missed the window probably by a year, but I know. Are high-risk patients with a past history of MRSA, ones that have been in the ICU anywhere, hospitalization anywhere in 12 months, you know, nursing home or skilled nursing facility patients. Some institutions use antibiotic therapy in the past 3 months, or anybody admitted with a skin or soft tissue infection on admission because you don't know what it is. And so some institutions limit, when they're not mandated by law, will limit their screening to this group of people, not every admission. And the big vulnerability is they're just doing Nares cultures. I mean, if you're really going to be active, you've got to do Nares, axillary, rectal, and any open lesion. That's the thing to remember. And remember, there's a distinct difference between colonization and infection. But in terms of cohorting and preventing it from going from one patient to the other, it doesn't matter. You treat them both the same in terms of isolation. We haven't had an MRSA outbreak in this hospital for, man, I don't think we ever had one after the USA 300 strain. So, you know, everybody talks about, we're all bad at washing hands. I'm as bad as anybody. I don't know what my score is. I don't think Chris ever will tell me the truth, but because, you know, there's silent observers supposed to be watching who's washing their hands and who's not. But, you know, it's one of the biggest problems we have. But, you know, hand washing is clearly critical. And whether we're identifying those people, cohorting them has made a difference. It has in some hospitals with a higher community incidence. In this hospital, we haven't had an MRSA outbreak. The one we had was, gosh, 8 to 10 years ago. We had 11 patients. It was nosocomial, clearly nosocomial. DNA clones, or DNA typing was done, and we knew it was the same bug that was on the catheter tip of a patient in ICU, came out of the chest tube in a patient that was on third for a week. And that, we did that once. We did MRSA education. We've never had an MRSA outbreak in this hospital again, which I think is a really important thing to remember when people start, you know, calling it, you know, what do they call it, Saint Staff, or they have some crazy name for it. St. Germs, that's what it was, you know. Yeah, most hospitals have these problems. And in terms of MRSA, you know, as a staff, we've done pretty well at preventing nosocomial MRSA. I mean, there's always work to be done, and we are always forgetting to wash our hands. But that's a pretty good track record in this day and age, because there are hospitals that struggle. Harborview in Seattle, for instance, the MRSA is endemic, and it's causing post-operative infections all the time. There is a low-grade, always positive rate of nosocomial MRSA in those bigger, complicated urban hospitals, tertiary care hospitals. So, you know, don't let yourself get beat up too much about that, because, you know, we've been pretty successful. So what are the precautions? One of the things that we're trying to push for both preoperative patients and patients in the hospital is chlorhexidine bathing. Patients at risk are given a chlorhexidine bath, barring open skin or other contraindications to it, are shown to have a much lower rate of MRSA acquisition in the hospital. It doesn't get pushed here a lot because we don't have nosocomial MRSA infection in the hospital. But if you had a patient who had MRSA who's being treated, encourage him to bathe with chlorhexidine once a day. Is not a complicated thing. 4 ounces of chlorhexidine soap and 4 ounces of sterile water or saline or whatever, and that's all you need to do a sponge bath to clean out the areas you're worried about, around the face and chin, and man, especially if he's shaven, in the axilla and in the perineum, any open lesion. Those are the things. That's the areas you want to clean. What about decolonization? That's been pretty controversial. In terms of in-hospital patients, it's not done because of the risk of increasing resistance in hospital organisms. Healthcare workers, it's pretty much not done unless they identify the healthcare worker as the source of the outbreak. That has been done, where they've had staff caring for patients who have contaminated wounds and colonized patients, and they've gone back and done DNA testing, and they've tracked it back to a single healthcare worker, but it's pretty uncommon. The only time, I think we talked about this, I consider decolonization is in a family setting where they're having recurrent outbreaks of first the mom, then the dad, then the 9-year-old, then the 2-year-old, and then the dad again, then the mom again. When somebody has gone through a cycle of 2 recurrent episodes of MRSA, boils, and so on, with a household member, that's when I sit down and talk about the pros and cons. And the only published data that has shown that any kind of efficacy in that setting in the household is the data where they looked at doxycycline and rifampin for a week, and they stopped recurrence in people that had more than 2 or 3 recurrences for a year by the time they reported it in 84% of those patients. So it was a pretty effective thing. The concerns everybody has is that we're going to induce resistance to the cheap drugs we have, and then we'll really paint ourselves into a corner. So there's a lot of chest thumping, but given the immediate circumstances of some families, I've done it, and it has almost never recurred, with rare exception, very rare exception. One of the things you do also is teach them about washing their hands in the bathroom. For these MRSA households, if you don't have chlorhexidine in the bathroom, when the kids use the toilet, they've got to use chlorhexidine. You've just got to be a Nazi about it for about a month while you're decolonizing with antibiotics. If you do all that together, you're lucky to get them to wash them for a week out of a month, but you tell them a month, or if it recurs, it's their fault, You got to put a little bit of the burden on patients, otherwise they ignore what you say, then they wonder why it fails. But if you're really careful about chlorhexidine washing and use of the toilet, the kids know it, the moms know it, the dads know it, and that it really makes a big difference. There's some reports on topical agents. Mupiricin's been the only practical one we know, although there's some mupiricin resistance. That's Bactroban, ointment or cream. There was a study done that tried to show if you used Bactroban ointment in the nose 5 days before admission, that you'd reduce the risk of postoperative wound infections. Didn't work. It did reduce the risk of having a Staph aureus postoperative wound infection, but it didn't reduce the overall risk of wound infections. Since then, though, they've done a study with cabbage patients where they used mupiricin on the first day, twice a day in the nose with the ointment, not the cream. The cream drips out too fast, warms the body temperature. You're licking it off your lips. It isn't pretty. The ointment is a little more viscous, and it's got to really be placed in the areas. On day 1 and then day 2, 3, 4, 5, they had a marked reduction of MRSA infections in their post-op sternal wounds, but this was in a hospital that had a high rate of nosocomial MRSA. So you gotta, you can make it work if you've got a background of nosocomial or high rate of community MRSA. In our community, where the MRSA rate's probably declining a little bit, it's hard to know how aggressive to be with that. It's probably something we have to think about. Systemic therapy is really important, especially if you're doing any kind of implanting any kind of prosthetic device, because if you know the patient's colonized MRSA, they shouldn't get cefazolin before surgery. They should get what? What? Vancomycin, right. So. I'm deaf. Nobody has any trouble yelling at me on the floor. Isn't it funny how quiet everybody gets here? God, I tell you. And then the other thing some hospitals had a terrible problem with is this environmental cleaning. And we all have, everybody bemoans hand hygiene, but environmental cleaning is another critical component. And you know, every time, less often than before, but we used to have, when there was a big turnover in environmental services and you get a new cohort of workers, that's when we'd see our nosocomial C. diff. And you know, in hospitals that have a lot of MRSA transmission, that's when you'd see that, because it lives for days on surfaces. You know, wipe your nose, wipe the surface of the tray. If it doesn't get cleaned, it'll be there for days, the MRSA. One rule of thumb, if you're in isolation, everybody asks, well, what do you really do? Do you have to gown and glove and everything? Most, in patients with an active MRSA infection, whether it's respiratory or a wound infection that has to be undressed, if you're going to come within 3 feet of the bed, you probably ought to have a gown and glove. If you're going to take off the wound or they're coughing, have a respiratory source, you ought to have a mask on. But if you're just going in to flush the toilet or take care of whatever in the bathroom and the patient's comfortable in bed and you don't have to do any hands-on stuff, you don't have to gown, glove, and mask in every room. You should wash your hands, of course, but it's within 3 feet of the patient or less, that's when you want to be aware you do need protective gear. So what are the antibiotics? The first decision is whether the patient's septic or not, right? Which is, you may think is a simple problem. It's not. We miss sepsis all the time. We talked about it in the first talk, and we can talk about it till the cows come home. But that's a really critical issue. And one of the things that make, aside from the usual screening order sheets, you can do is to be sure if you have any question on a patient with a history of MRSA or suspect MRSA, is that you get some arterial blood gases. Because if there's any evidence of early respiratory alkalosis or metabolic acidosis and respiratory alkalosis, then you've got to assume they're septic. If they're not, the next question you ask is, do you have to drain the focus of infection? Do you need to lance the boil? Do you need to open the wound? What do you need to do? Because you don't want pus under pressure. Antibiotics don't penetrate pus under pressure. And the third question they should ask themselves in the ER or wherever you see these patients is, do they require hospitalization? How do you decide that? That's complicated. It's not simple. But usually, what's the thing that keeps people in the hospital? Why do you decide to put them in on IVs instead of sending them home on Bactrim? What do you get, John? What do you get in the ER? You should know this. I know. What's that? How do you think an ER doc makes the decision? Somebody comes in with a big boil on his leg. Let's say he doesn't have a fever. How do you decide whether he's going to get oral or IV antibiotics? That's a good. That's one. What's another criteria you use?
Being able to afford the.
Sure, that's practical.
What about the WBC?
There you go. You start looking for SIRS markers, right? If there's evidence of systemic inflammatory response, an elevated white count, elevated CRP, elevated sed rate, that's usually too slow. That's an awful insensitive test to use. But a CBC, with or without bandemia, 10%. These are all criteria that are fairly well published. Or leukopenic, if they have an abnormally low white count. Those are patients that are higher risk for having bacteremia. And if you think there's any chance of bacteremia, they should be on IV therapy till you know otherwise. Because the standard of care, if you grow Staph aureus, whether it's MRSA or MSSA, is 14 days of IV therapy, minimum, with a positive blood culture. I came from a meeting where the head of ID at Duke, Ralph Corey, was the advisor for this company, and they're introducing this new MRSA antibiotic. And this company that has spent, I am not kidding, tens of millions of dollars on this compound, developed a protocol where they were going to let people treat these patients with IV vancomycin for less than 14 days. This is like after they spent tens of millions of dollars. And it was one of those embarrassing moments where, somebody stands up, hey, you've got toilet paper hanging off your leg. I mean, it's like, don't be this stupid, but I've got to stop it, even if it's way too late, because, having them walk in to do surgery with toilet paper out of their leg is even more embarrassing, or wherever they're going. I mean, this was a catastrophe. It was the most embarrassing thing I've ever witnessed medically. It was embarrassing, because these are people responsible for huge amounts of money. And Ralph Corey had to say, you cannot defend treating a patient with positive blood culture for Staph aureus, whether it's MRSA or sensitive staph, for less than 14 days. Period. End of discussion. Why does he say that?
Because you're going to create more resistance than...
No, that's theoretical, but even for that one patient, what might happen that you wouldn't want to get behind the curve on? What might get seeded? Heart valve. That's all because of endocarditis. It's such a horrible consequence that you couldn't defend yourself in a court against failure to treat. That would be a clear-cut failure to treat. Nobody's going to stand up and defend you medical legally if you have a positive blood culture. So you back up a little further in the ER, who's like always getting shot at by everybody, is you've got to make a good decision about whether this patient needs IV therapy. And the best decision is when you have any concern that they might be bacteremic, and you draw blood cultures. Now you can make mistakes and draw blood cultures and send them home because you just don't think you're just being cautious, and bring them back in if the culture used to be positive in 24 or 36 hours. You're okay if you send them home on oral therapy as long as you get them back and get them on IV therapy for 14 days. So you can make mistakes like that, but you don't want to make mistakes of not drawing the blood cultures. Because if somebody has isolated Staph aureus from a wound, came in with a high white count, you didn't draw blood cultures, you treat them with Bactrim for 7 days, and they show up with endocarditis 4 weeks later, get out the checkbook. I mean, it's all over but the shout. So making that decision isn't a trivial one, and drawing blood cultures is usually a better choice than not. But, backing up further, the white noise the poor walk-in and ER docs have to deal with is that 99% of these patients don't have an elevated white count. They have boils, they have no elevated CRP, they don't even have a lot of erythema around it, or they might have a little, and you get numb to it day after day after day. And the ones that blindside you are the ones with a white count of 17,000 and elevated CRP, and you don't think to draw blood cultures, and they don't do well, and they end up coming back in. But like I said, deciding on hospitalization is really deciding whether you need IV therapy. Deciding IV therapy is really whether you think there's a significant chance, or as I'd say is about a 5 to 10, 1 out of 20 chance they might have a positive blood culture. You should put them on IVs. Can you put them on IVs as outpatients? Absolutely. If they're ambulatory and you have those resources. But what antibiotics are you going to prefer? Here's a patient with an aggressive skin and soft tissue infection, high white count, you're putting them in the hospital. What's the drug of choice? IV vancomycin, right. Why do we use that? Why don't we use IV linezolid? Why wouldn't we use IV linezolid even if it was cheaper than Vanco? It's static. It's bacteria static. It won't protect you from endocarditis. You're trying to kill as many bugs in the first 24 to 48 hours as you can. So vancomycin will give you a 3-log kill in 24 hours. So you had 1,000 bugs per cc of blood on the minute you dose them with vancomycin. 24 hours later, you'd have 1, maybe. That's a 3-log kill. When you use a drug like daptomycin or telavancin, it's a 7-log kill. So you'd have to have 1 million bugs per ml, which doesn't happen very often, and in 24 hours you would have 1. But there's the concentration-dependent killing, the rate of killing is so much better with these new antibiotics that if there's any increase in vancomycin resistance over time, we're going to be shifting to those more and more. The problem we have is the more you put pressure with those antibiotics on those bugs, there's reports already of adaptomycin resistance popping up everywhere in MRSA. MICs of 4 and 8, which make it virtually ineffective. So, you know, it's going to be a constantly moving target. Now, if you think, this isn't key, if you think they're septic, and they have like and you're worried about necrotizing toxic shock, you can't use a drug like clindamycin or linezolid, Zyvox, alone because it's not cidal. But you can add those drugs, preferably linezolid, because they inhibit protein production and they inhibit toxin production by the organisms, because you haven't killed them all, at least for 24 hours. So every bug that's surviving and is producing more and more toxin while the vancomycin's working on its cell wall synthesis, okay? So if you have any evidence of septic shock, you not only use a bactericidal agent like Vanco or Dapto or Telavancin or whatever comes out next, you can add linezolid as a protein cis inhibitor. You don't use clindamycin for that unless you know it's sensitive staph. Then it works pretty well too. Or you know it's group A strep, because clindamycin inhibits toxin production of group A strep. But linezolid inhibits it for group A strep, MSSA, and MRSA. And so until you know it's not MRSA, linezolid is the one that's preferred in those rare situations where you're worried about toxic shock syndrome and bacteremia, not just bacteremia. Does that make sense to you? There are a lot of physicians who don't understand that or don't use that, and that's not necessarily because they don't know what they're doing. There is a deeply entrenched concern that goes back 50 years that when you use a static and a cidal agent together, you might inhibit their activity. But clinically, in the case of group A strep toxic shock and MRSA toxic shock, that's never been shown to be true. The classic demonstration of inadequate therapy was when penicillin and tetracycline were used together in strep pneumo infections. If you add tetracycline to penicillin, penicillin loses its effectiveness against strep pneumo because it inhibits the bug, and when it quits cell wall synthesis, penicillin can't kill it anymore. So in some limited circumstances, there's a concern for that. So you can't be overly critical of clinicians who don't jump on that protein synthesis use. And I try and limit it to 3 days if that's all I'm using it for. But, you know, in terms of what the practice guidelines right now, that's what's in the practice guidelines. But it's not, you know, it's not set in stone. And you can argue this case till the cows come home. But right now, that's what we prefer. And if there's no evidence of serious, you use oral doxycycline, minocycline, or trimethoprim sulfa. And again, you guys know why I don't like to use this for MRSA, right? Why don't I like to use trimethoprim sulfa? I mean, it's cheap. If you remember that you got to use higher doses, like 1 double strength 3 times a day or 2 twice a day. But what consequences do you get with 7 to 14 days of Bactrim that make it confusing sometimes? Oh gosh, you've got to remember this. What's the most common complication of using a sulfa drug? Rash, right. So you have a patient with a staph or strep infection with a rash. What's the rash from? They show up in the office 3 days later. Is it a sulfa allergy or is it toxic shock? I mean, we presented the case of a young girl who came in here with what they thought was a sulfa reaction, gave her steroids, and what she had was MRSA toxic shock syndrome. And she got sicker and more bacteremic. Got a septic phlebitis, got septic emboli, because the rash was thought to be the sulfa drug. So, is that unusual? Absolutely. Should you not use trimethoprim sulfa ever? Of course you should use it when it's cheap, and especially in kids under 8, you can't give them tetracyclines. You're always going to be forced, but I always tend to find any way I can to avoid that, just because I hate that consequence. So, here we go. Case report. Then we'll move on. 55-year-old lady admitted with a painful right breast swelling, 7 days after lumpectomy. Temp 102, blood pressure 92/40, heart rate 120, respiratory rate of 32. Until proven otherwise, she is septic, right. And her surgery was performed at the University Hospital and appeared to be uncomplicated, but she's allergic to penicillin. So what antibiotics do we choose? Vancomycin. What else might we choose? Linezolid, yeah, Zyvox, to inhibit toxin production, because this could be toxic shock. Until you know it's not, for 24 to 48 to 72 hours, adding linezolid is very reasonable. You could use daptomycin. You could use telavancin. You could use iridovancin if it becomes approved, which it probably will be. You could use a one called dalbavancin. Iridovancin and dalbavancin have such long half-lives, you give them once a week. And iridovancin for uncomplicated skin soft tissue, you give it once, 1,200 milligrams in the ER, you're done. Only reason it didn't get approved by the FDA is that they didn't have a high enough percent of MRSA patients. And the FDA said, hey, if you're going to give us expensive antibiotics that cost an arm and a leg, you've got to show us something that helps. You've got to show us that's active against MRSA and doesn't fail. And when you don't have, when you only have 5 or 10% MRSA in a skin soft tissue infection, and the prevalence rate is 40 to 60% in some communities, the FDA isn't going to promise everybody it's going to be active. So that's why they still haven't approved iridovancin. But when it comes available, all those issues that you're concerned about with how do you decide IV therapy, whether people are going to buy it, whether they're going to fill the script, and you guys know that hardly, and the people at community health really have a problem with this, because even when they supply them with the medicines, getting them to take it is like moving heaven and earth. I mean, just that whole follow-up issue is a nightmare in every situation, some more than others. Drugs like that would be helpful, but we got to know they're active against MRSA. I'm going to talk briefly about VRE, and these are just some definitions of it. And about 6 months ago, when we really tried to restrict and reduce our use of daptomycin and other MRSA agents outside of vancomycin, the first thing within 2 months that we saw in surveillance cultures was an increased isolation of, with higher use of vancomycin. What happened? What did we start isolating?
Getting more VRE.
VRE, sure. Suddenly it was in stools, it was in urines, in chronic indwelling Foleys. The collateral, the unintended consequences of trying to save money on one thing. But was it really an expensive complication? I don't believe it was. We almost never have to aggressively treat MRSA. You pull out the Foley, you may give them, if it's sensitive to ampicillin, you're lucky. It's cheap. If it's not, and you have to use daptomycin, you don't have to use it very long if you pull the catheter 5 to 7 days. But it is not a virulent organism. This is the classic example of one of the more highly resistant, wimpiest bugs that has ever been funded. And there are people who write about this like it's the plague. And it's a joke. It's not a very virulent bug. It loves slime. If you've got a catheter that's been a urinary catheter that's been in too long, if you've got an IV that's been in too long, if you have a chest tube that's been in too long and the patient hasn't really been decorticated very well, you don't set up shop. But, it doesn't like a blood supply. It likes patients to be on broad spectrum antibiotics so there's no other bugs to inhibit it. Because if you put E. coli in a bladder with VRE, the VRE doesn't survive. I mean, it's a marker for a patient whose immune defenses, especially the mucosal and the skin integrity barriers, has been corrupted. And the definition of VRE is vancomycin MIC of greater than or equal to 32. And the intermediate range is one that's reported as intermediate, but it's really considered resistant because you shouldn't use vancomycin. You'll just kick up the MIC. It's not a bug that requires shock and awe. Do we want to isolate them? Yeah. Do we not want it to be spread to every patient who's got an IV line or a Foley catheter? And of course not. Is it really hard to get rid of on surfaces? It is. It's on tables, bed rails, and one of the most common transmissions in hospitals is when people will walk into the VRE patient's room with gloves and they'll touch the bed rails but not touch the patient and then kind of think, you know, they're in a hurry, they get called out, they don't change their gloves, they get down the hall and they use the same gloves, and the VRE and the bed rail to the glove goes back to the bed rail or to the patient in the next room. VRE loves bed rails. That's why we say, if you're going to get within 3 feet, glove up, but don't forget to take them off when you leave the room. One of the other problems we have is the damn glove boxes, right? The gloves, the cheaper, the lower the price, the more likely you're going to get them ordered, right? Any hospital, they don't care. And they're packed in there like sardines. And you pull one out and 10 of them pop out. Half the goddamn box pops out. And then you pick it up with your bare hands before you put your gloves on, right? And you pick it up with your bare hands and you shove it back in there. And now you've got VRE loaded glove box. I'm not kidding, that's been described. And you know, at what point is it cheaper to get a little bit better glove? Or if you could, you make a fortune if you can invent a Kleenex box for gloves, where just one pops up. When you pull it out, another one pops up. I'm not kidding you, you could make a killing. If you can figure out a cheap way to make that happen, you know, there's all kinds of crazy stuff. I told you about the shark skin. Have you read about that? Did I tell you about the shark skin? Well, what's unique about sharks among whales and all kinds of ocean-going fish? What doesn't grow on them? Barnacles, slime, bugs. They almost have they're virtually sterile skins if you swab them. You pull a shark out of the water, you culture it, it's really hard to find bacteria. You pull a salmon out of the water and swab it, it's going to be loaded with some kind of hydrophilic bug like, you know, Enterobacter, Serratia, Pseudomonas. It's going to have something, right? And then they also have barnacles. So these guys went and did electron microscopy, and there's a unique shape to the shark skin. It's a diamond shape, and it has little lifted ridges going the way they swim, right? So it's aerodynamic or whatever it is with water, hydrodynamic. And they showed that bacteria it's really difficult for some reason. This is nanometers now. This is like a nanometer scale. It's hard to create biofilm on this bizarre surface, this diamond-shaped ridge surface they have. So, you know, I hear that and I think, my God, that's what they need to make the prosthetics out of. No, you know what the company's doing? Because the market, this is the best market. They're making wallpaper for hospitals with this stuff. And tray surfaces and floor surfaces, and that's what they're doing. I mean, because it's simple. It's the simplest, best way to get their venture capital money back. But there's all kinds of crazy stuff. But I think that's pretty exotic and high tech. But getting back to just trying to get a glove out of the box without contaminating the rest of them, and I'll bet you 1 out of 3 times you pull out more than one glove.
Every time.
Every time. Yeah. Amen. On the other hand, you know, sort of like the inventor of the staple, the surgical staple, you know, you would never have to go to a CME talk again. So let's talk about gram negatives, okay? And the infamous ESBLs. I think I got my slides out of order, but needless to say, extended spectrum beta lactamases are enzymes that infer resistance on gram-negative bacteria. You guys remember what those are, right? Enterobacteriaceae, E. coli, Klebsiella. Give me a few more. Acinetobacter, sometimes we'll talk about that. Proteus, yeah. Pseudomonas aeruginosa. Enterobacter, Citrobacter, Serratia, remember? Serratia marcescens. Why the Virgin Mary bleeds tears in the right temperature is the Serratia marcescens starts making the red pigment at the right temperature and the right salt concentration. That's why the statue in Italy bleeds tears for a few weeks every year in the right conditions, in the right temperature, with the right... What was that too?
It's a miracle that bacteria is there.
But these are the hydrophilic bugs that colonize the gut primarily, and sometimes cause infection in the urinary tract. And these are the bugs that are starting to be described as, or have developed what they call extended spectrum beta-lactamases. We've been fighting beta-lactamases all along. The minute penicillin was introduced, the bugs developed an enzyme that would break the ring, the beta-lactam ring, which is what kills the bacteria by interfering with cell wall synthesis. So cephalosporins were a fancy beta-lactam ring, kind of a different ring, not even beta-lactam anymore, that the bugs couldn't fight. But then eventually the bugs came up with cephalosporinases, right? And so we came up with drugs like amoxicillin clavulanate, which is augmentin, amoxicillin sulbactam, which is unison, piptazo, piperacillin tazobactam, and what they did was inhibit the enzyme that broke the ring up. So we thought we were getting pretty good. And then the bugs developed extended spectrum beta-lactamases, which tazobactam can inhibit. So all of a sudden, piptazo or zosyn doesn't work anymore with these bugs. And the beta-lactams we're talking about are not just penicillin and cephalosporins, but also include the monobactam aztreonam. I'm only putting this in here because with pressures from corporate offices, this may become used more and more generically because it's cheap, and in a lot of cases it's quite effective for gram-negative infections. In our system, I think we might start seeing a lot more, you'll see a lot more aztreonam use. Carbapenems are the best antibiotics, this is quite simple, for infections caused by these organisms. Even if the MIC says it's sensitive to trimethoprim sulfa, it often won't work clinically. Carbapenems, this is important to remember, are the best antibiotics for true infections caused by gram-negatives producing extended spectrum beta-lactamases. So what carbapenems do we have? For a long time we only had one. Imipenem, yeah, but now we have doripenem, and a lot of hospitals have always used meropenem. Yeah, we had imipenem first. That's Primaxine. The problem with imipenem was you could get seizures. It lowered the seizure threshold. Doripenem doesn't, and I don't think meropenem does either. Meropenem is probably going to become our carbapenem of choice, according to Mike and the powers that be. Meropenem, yeah, I think they're going to try and consolidate so all the hospitals and sister charity use one carbapenem. And it'll probably be meropenem, which is fine. It's used a lot by pediatricians, and neonates especially. You might have gram-negative meningitis or concerns about gram-negative sepsis and those little creatures I don't deal with very often. So it's the isolates of these bugs, and especially Klebsiella pneumoniae, Klebsiella oxytoca, Pseudomonas aeruginosa, or Proteus that are likely candidates. Now, there's an august body called CLSI. What does that stand for?
Lab scientists.
Collaborative. I can't even remember. I'm not setting you up. I don't have a clue.
Clinical Lab Scientists Institute.
Yeah, it's an acronym for some organization of people who get together and make decisions about what MIC is going to be sensitive and what's not. And so in 2010 they came out with these new breakpoints for these bugs that are 1 to 3 times lower than the original breakpoints. Have we adopted them? I can't get the docs to give Decadron before antibiotics and strep pneumo meningitis. How the hell are we going to explain? Now this is a logarithmic change here, dropping the sensitivities probably in half to some of these bugs to whatever the usual antibiotics that are used in here. We've held off doing that, and most hospitals have. There's a real disconnect, and this is going to be kind of a quantum shift, and it may not happen for several years. Because if you use those lower breakpoints and then the bug just shows up resistant, you don't need to do any special testing for ESBLs. But it's a challenge because A, they might not read the MICs anyway, or B, if they read them, they might think it's an error, and if they just use more of that antibiotic, they can overcome it. Do you see what I'm saying? And there's a lot of concerns that clinicians are going to fumble this ball. And so we haven't done that, and we still do some special testing for ESBLs. What triggers your ESBL test? Because you'll see the reports, E. coli. Connie, what do you use as a trigger to test for an ESBL?
It's just on our vital panel.
It just automatically
Yeah,
does it. So it picks all these organisms and probably screens every one of them with an MIC, etc. So here's a patient that showed up 2 years ago in my office with fever, flank pain, dysuria. EUA showed 50 WBCs per microfield, and her culture grew 100,000 E. coli. And she was prescribed Cipro, 750 twice a day. But after 3 days, still had a temp of 102, still had flank pain. White count was was not only still elevated, it was higher. What's going on? What's that? Yeah. How come though? After 3 days of Cipro. Yeah. It's resistant to Cipro and Levo. We just see Levo, but virtually if one's intermediate or resistant, the other will be, or will soon be. That's one possibility. What's another possibility? What's the primary defense against urinary tract infections? Come on, you guys. This is like an integrative thing, you know, or you remember what you heard the last time, and you bring it, you know what I'm saying? Forward flow, right? So it could just be she's obstructed, because if she had ureteral obstruction and an increased pressure in the ureter, none of that Cipro's getting into the urine. So you've got to be sure she's not obstructed by ultrasounding or CTing her. Do something to be sure you don't have post-renal obstruction, because if you do, I don't care what the sensitivities are. Nothing's going to work. With me? Third possibility is she's already developed a perinephric abscess. Same problem. Pus under pressure, you're not going to penetrate with Cipro. So you've got to have all those things in mind. You can't jump right to resistance when you see failure of an antibiotic. You got to step back, take a deep breath, make sure all the pus under pressure is drained, there's no urine under pressure, everything's working like it should be, there's no biliary tract obstruction, because nothing penetrates in the biliary system at all when it's obstructed, right? All those things are more important than worrying about a resistant bug. However, in this case, I got an ultrasound pretty quickly, and she wasn't obstructed. And she indeed had an E. coli that was not just levaquin resistant, Cipro resistant, but ESBL positive. What antibiotics do I have? Or a carbapenem of some kind, right? Why did she have this? This was an outpatient in Butte, Montana. She's not a skilled nursing facility. She hadn't been in the hospital for years.
Maybe she took antibiotics.
She might have, but she didn't. That's a good point, though. Do you have any idea? What's that? Oh, yeah. That actually is a high risk thing. Had she been living somewhere? Excellent question. She, in fact, had been to India. Did a spiritual thing. You know where she floated? The Ganges. What country has the highest incidence of ESBLs, let alone other types of resistance we'll talk about? Asia, India in particular. Sky high. Foreign travel is a high risk. Next patient I saw in the office 6 months later had been to the Bahamas or Jamaica. Same thing, otherwise healthy person. Antibiotics are loosely controlled and regulated. They're used like water. Our E. coli have a resistance rate of 10 to 15% or more to the quinolones now, whether they're ESBL positive or not. That's pretty scary. Because what the hell are we going to use? So what did I have to use? I had to use a carbapenem. So here's a patient who actually wasn't sick enough to be in the hospital. You have to use IV therapy, so I have to use an IV carbapenem. Did I wimp out and use an easy one? Yes. I used ertapenem because it's once a day. I have since learned that that's probably not the best carbapenem because it fails more often. You probably should use meropenem or doripenem or imipenem. The problem with that is you can't do that at home very easily. then you start, and then all of a sudden it becomes very expensive and complicated, and you know, you call Walgreens Option Care. You must be full Walgreens. Are you from Walgreens Option? Warmsford. Oh. Well, you don't even have these drugs close to the formulary, probably. No.
We just sent them to you.
Yeah, but you know that's an issue, and I don't know what we're going to do. I mean, this is getting pretty crappy, and it gets worse. Before we go on to how bad it gets, let's just talk about the risk factors for these ESBLs. And you guys have figured this out. Length of hospital stay in some urban areas, central IV or arterial catheters left in too long, emergency abdominal stage B. I don't know. Am I getting sarcastic about surgery? I don't know. Sorry, guys. Gastrostomy or jejunostomy tube, that's not a surprise because it's colonization in the gut and exposure to antibiotics. It really, especially if you can form a biofilm on a gut tube, you know, hello. Nursing home, skilled nursing facility, patients undergoing dialysis, and last but not least, foreign travel to high incidence countries. And the antibiotics that are preferred are imipenem, doripenem are about equal, but they're preferred over ertapenem. And even when the in vitro MICs say it's sensitive, ceftazidime and cefepime, which is going to become the ceftazidime of our institution for Pseudomonas aeruginosa, pretty quick. So you've heard two antibiotics you've never heard used a lot that are going to become the formulary antibiotics here. Cefepime is like ceftazidime. Very little gram-positive coverage, very good Pseudomonas coverage and gram-negative coverage. And ceftriaxone, even when it says the MICs are okay, it's unlikely they will work clinically, and there's been reported failures. And for the same reason, the tazobactam isn't effective against these ESBLs. They're not active, and quinolones are also likely to fail, not because of the mechanism, but because of the genetic linkage with that quinolone resistance and that ESBL gene. They're linked, so when one's transmitted to the bug, the other goes with it. And why they're linked, I've never quite understood the epidemiology of it. So that's just empiric and important to remember. You'll see it on the MIC panel. So what did the bugs do? So we came up with carbapenems, so what did they come up with? This is an old story. You're going to hear it over and over again. And, 10 years from now, if I'm not in the crypt, I'll be trying to tell you about the door. There'll be some other aces with 2 S's or 3. It's a joke. But these are carbapenem hydrolyzing beta-lactamases that are able to infer resistance to carbapenem for the Enterobacteriaceae we talked about. E. coli, Klebsiella, Pseudomonas, Acinetobacter, Citrobacter serratia, and these are called KPCs because they were first recognized in Klebsiella pneumoniae. So there's the K, there's the P, there's the C. So KPCs are the most important. Why? Because clinically that's what we see the most often. There are actually 4 different classes of these, and some of these there's all kinds of complicated names they use, but I'm not going to bore you with them because they're not clinically important to keep in your head. They're sort of like white noise, which is what fills my head most of the time. But anyway, they're not important. But these KPCs are important, and we had our first KPC producing club in the hospital here. When was it? Earlier this year. Was it just this year? God, it seemed like it was a year ago. Colonizing a wound in a patient from a nursing home. I will guarantee you there are other patients in that nursing home and any nursing home we have, or probably everywhere in the country, but if there's one, there's probably 100 that we haven't identified, okay? They colonize the environment and the GI tracts of these patients and patients with indwelling Foleys. Why do we get them? Probably somebody transferred from Seattle or something that's probably been brought in. I hate to say it, but most geneticists, microbial geneticists, think all these ESBLs and KPCs, the carbapenemases, which is too hard to pronounce, so KPCs is better, all originated in antibiotic overuse in the U.S. These really are hospital-developed super resistant bugs. Are they super virulent? Not often. Are they trying to create a lot of panic? Absolutely. There are biotech companies with a lot of venture capital coming out with antibiotics that now have beta-lactamases that will inhibit the capex. We've already done one of these trials in this hospital. That was the Calixa trial. In some urban areas and high, tertiary care centers, there might be a high use for this. I can't see it becoming a real profit maker, and so a lot of companies aren't spending, big companies aren't spending a lot of money. There's just a bunch of biotech companies gambling on the fact that finally one of these highly resistant organisms is going to cause a nosocomial outbreak, and it'll kill some politician's kid or family member, and that's what will drive the development of these drugs. Do I sound cynical? That's life in the U.S. Yeah.
No, I was reading that this SME factor is these soldiers coming home are being wounded soldiers.
Right.
The wounds are being infected with.
Well, Acinetobacter is a monster of a whole different ilk.
That they're calling it Iraqibacter now.
Yeah, it's endemic in the VA hospitals, it's endemic in Harborview, and in Portland and UCLA. And it's a soil organism in the Middle East. And so it's an environmental organism that is just like Pseudomonas and everything else here. If you're not careful about hand washing and cleaning the rooms and washing the patients and sterile technique, it'll contaminate. And it's very much like, it's sort of like Pseudomonas in its ability to kind of colonize sinks and all that kind of thing. And really, it's really almost impossible to eradicate from the environment once it gets in a hospital environment.
I read there's 3 places.
But it's not horribly virulent.
No, it has to be wounds or.
But what it had, yeah, I mean, the first Acinetobacter case I was ever called about was Pete Serini. It was in Germany. He was taking care of a Canadian soldier that had a hatchet wound to his head. And so he had a chronic ventricular cutaneous fistula. They could never close the fistula that was caused by the infection with Acinetobacter. And he was never cured of that. He lived for months. They tried to decompress him. They put in Ommaya reservoirs. Those are little teardrop, what do you call them? Bulbs, rubber bulbs that are like a portacath type concept that you put down the fissure into the ventricle, and then you can inject through the skin and inject tobramycin and aminoglycosides. It was resistant to all aminoglycosides, and they eventually killed them. But that's the kind of bug it is, and it's not horribly virulent. What really scares the hell out of me are KPCs in organisms like Salmonella, because these are kind of environmental bugs. This is a bug that causes diarrhea and infects chickens that are fed quinolones and tetracyclines and already are a hotbed of multiple drug-resistant organisms, right? And the animal industry is a huge generator of these bugs. And if that starts causing human outbreaks, we're in trouble, because they can colonize people for years, especially if you have gallstones. You'll never clear it. You'll never clear it, even if you stop having diarrhea. So that's, to me, there's going to be a few of these Enterobacteriaceae that are going to be a much bigger worry than some of these environmental bugs. So how do we know that most Klebsiella and E. coli without carbapenemases have MICs to imipenem or meropenem that are less than that? When they're higher than 0.5, it's very likely they're producing carbapenemase. That's how we'll know they're there. We'll see high MICs to imipenem. That's the deducible one. If it's sensitive to imipenem, it's sensitive to meropenem, it's sensitive to doripenem. If it's got an MIC of 1 or more to imipenem, then we very likely have a CAPAC. I think we'd have to send that out, of course, to detect it. But did we detect that here?
We had to send it out for the conference.
Did we? To confirm it, yeah. The thing about Pseudomonas and Acinetobacter that makes it kind of a nosocomial nightmare is it can become carbapenem resistant even without a carbapenemase. And they have metallo beta-lactamases. It gets complicated. We don't have to worry about it. But that's why this Pseudomonas and Acinetobacter are the real nightmare bugs. I've seen one Acinetobacter baumannii infection
here, and it was in a septic joint in a rheumatoid patient on immunosuppressives who'd been hospitalized in Missoula. It's the only time I've ever seen it. I don't think have we ever had one here other than that? Maybe one, if any. But we have had our first KPC, and I think that's the tip of the iceberg. There's probably no doubt. And what are we going to treat it with? Well, the drugs that are on the books are tigecycline, bacteriostatic drug that doesn't have a great mortality statistic in certain intra-abdominal infections, so most people won't use that. Colistin, been around for 40 years. You'll deafen them, you'll give them neuropathy, you give them neuromuscular blockade, you'll kill their kidneys, you might cure them. Whereas Trianam, if it's tested specifically, may be active against Acinetobacter. But with ventilator-associated pneumonia, UTIs, central venous catheter infections, bacteremias, these are going to be really tough pharmacologic challenges. I'm not going to bother with that one. Let's do the true and false, and then we're done.